Mr. Chairman, ladies and gentlemen, thank you very much for the opportunity to present our work today. My perspective is somewhat different from some of the previous speakers, and I hope that in presenting our modest series, I'll be able to demonstrate that in a low-cost and low-infrastructure environment like the National Health Service in the UK, it is possible to develop and grow a minimally invasive and hybrid revascularization program successfully. Patients are carefully selected with appropriate preoperative assessments and very careful study of the preoperative angiogram, and that, I believe, is the key to the success of the program. This is an example of a patient who has complete in-stent restenosis within the LAD with occlusion of the LAD, and the right coronary injection shows a stenosis in the mid-right coronary artery and a suggestion that the LAD may be patent and available for a graft during an EndoACAB. Through thoracoscopic instruments and a harmonic scalpel, we open the pericardium and first of all determine whether or not it is possible to complete the procedure endoscopically. And here you can see the LAD, and it is also, because of the tactile feedback, possible to palpate the LAD. Once the site of the anastomosis is determined, we use a Verus needle to mark the intercostal space. The lemur is then harvested using the harmonic scalpel, and a small anterior microthoracotomy performed, followed by off-pump anastomosis of lemur to LAD using a shunt. Our results up to August 2013 show a total of 367 procedures with no mortality and no neurological complications. Other complications also remain low. The conversion rate was 4.8%, and the large majority of these were caused by pleural adhesions in 7 patients and intramyocardial LAD in 4 patients. Of the 367 patients, 92 went on to have hybrid revascularization. Patients were very carefully selected and discussed prior to procedure in the MDT, or what you call as a heart team, and we made sure that it was possible for the cardiologist to complete the PCI procedure after the EndoACAB. While our cardiologists are competent at performing chronic total occlusion reopenings, we do not accept those patients for EndoACAB and hybrid procedures. This is an example showing a patent lemur to LAD after the EndoACAB and PCI to a low syntax mid-right coronary artery lesion of the same patient that we saw earlier in the presentation. In the hybrid group, again, there was no mortality and no neurological complications, and 8% rate of atrial fibrillation. Medium-term survival using the UK demographic service, the EndoACAB survival at 3 years was 97.5% and hybrid at 97%. When I looked at the distribution of coronary artery disease in the hybrid group, a large majority, i.e. 80 out of the 92 patients, had 2-vessel disease, 9 of which were disease in the diagonal vessel, and 12 had 3-vessel disease, but of these, 2 were disease in the right coronary artery and the diagonal. Since August to now, we have performed another 55 cases, and our total experience is 412 patients, again with a very low complication rate. This is a graph showing the increase in our referrals and EndoACAB program with 75 cases performed in the last financial year. I hope that this presentation has shown that in the absence of high cost and latest robotic equipment, it is possible to deliver endoscopic and minimally invasive surgery for coronary revascularization to patients with low mortality and morbidity. Thank you.
Thank you, Dr. Yadav. Please, could you take a seat? Yes. So the last presentation is